Hello, my name is Bogdan Ciopleias and I'm a neurologist working at the County Clinic Hospital and at the Faculty of Medicine of Transylvania University, Brașov, Romania. And I would like to welcome you to Back to Bedside, a program supported by the European Stroke Organization. I will present you a case of a stroke imposter. The patient, a 26-year-old male with an unremarkable medical history, some episodes of tension-type headache, especially in his early adolescence, presenting sudden onset severe left-sided headache with a 9 out of 10 of the intensity, right-sided hemiparesis and mixed aphasia. No prior risk factors for stroke and no prior migraines before his admission. Symptoms appeared almost 2 hours before his arrival to the hospital. From his parents, we found out that he had some rhinopharyngitis symptoms 3 to 4 weeks before hospital admission. His family history is unremarkable. His father was diagnosed with type 2 diabetes a couple of months before his event. He has quite an active lifestyle, no smoking, no drugs intake, and only some social drinking. At the neurological exam, we found out that the patient presented mixed aphasia, right-sided hemiparesis, with a 2 out of 5 on the upper limb, 4 out of 5 in the lower limb. His NIHSS score was 12 at his admission. His blood count was unremarkable, and the CT scan and the CT angiography detect any lesions or LVO. The aspect score was 10. In this slide, you can see the prior CT scan of the patient. What would you do with this patient? Would you thrombolize him? Would you continue the assessment using other imaging methods such as MRI, perfusion CT, or angiography? Would you continue doing other investigations, or would you wait and see? So what did we do? We thrombolized him, and we continued the assessment using other imaging methods. We performed an MRI scan a couple of hours after his admission. We continued doing other investigation and other blood works in the following hours. And the most important thing that we decided was not wait and see how the symptoms will evolve. The main things that we thought about in the emergency facility was an acute vascular event, an ischemic stroke for which we had thrombolysis at our disposal. We thought about migraine with aura, we thought about an infectious event. Because of the intense headache, we thought about reversible cerebral vasoconstriction syndrome, but the lack of typical type of headache, precipitating factors, and the lab work excluded the diagnosis. We also calculated the RCVS2 score. The result was -2 points, so the result was negative. We considered at that moment, using what we had as diagnosis tool, that the best option for the patient was to thrombolize him. What happened post-thrombolysis? We didn't observe any significant improvement at 2 hours on the NIHSS score. The patient presented 10-point score at 2 hours. But the most important thing happened 8 hours after thrombolysis, when symptoms resolved spontaneously. As a clinical course, we observed another 2 similar episodes in the next 10 days, each lasting from 4 to 6 hours, associated with severe headache and mild hemiparesis. We did perform follow-up imaging, but we didn't observe any abnormalities on the MRI scan. So this is the MRI that we performed 6 hours after thrombolysis to our patient. We didn't observe any abnormalities. In the following days, we did a lot of laboratory testing to our patient. We managed to do a lumbar puncture the next day when we observed that the patient presented an increased level of white blood cells with lymphocytic predominance. He had a mildly elevated protein level in the CSF, and the glucose level was normal. The bacterial culture and the real-time PCR for viral testing was negative. So, how to handle this case? Headache with neurological deficits and cerebrospinal fluid lymphocytosis is a rare self-limited syndrome that is characterized by multiple episodes of headache with temporary neurological deficit and cerebrospinal fluid lymphocytosis within a period of 3 months. It affects mostly young people, and HaNDL is commonly preceded by a final illness. A possibility is that this syndrome is autoimmune as origin. There is no specific treatment, but the syndrome does not leave any sequel at all. On this slide, you can find the International Classification of Headache Disorder 3 diagnostic criteria for HaNDL syndrome. Our patient presented after discharge and had 2 episodes of mild headache associated with paresthesia. We did perform follow-up imaging after his discharge, but without any changes at all. As a take-home message, HaNDL syndrome is a rare stroke mimic, and the prompt recognition prevents unnecessary treatment. But in an acute facility, it is sometimes really hard and challenging to determine if a patient presents a stroke mimic or not, especially if you do not have advanced imaging or testing at your disposal. An advice is to consider CSF analysis when imaging studies are normally in your patients. At the end, I would like to thank you for your attention. See you soon.